Professor Ziad Hijazi, Professor of Pediatrics and Medicine, Weill Cornell Medicine, Chief Medical Officer, Sidra Medicine, Kota. Currently, Prof. Hijazi is involved in evaluating percutaneous valve implantation for defected pulmonary valves, senile aortic valve stenosis, and mitral regurgitation. He did the first percutaneous human implantation of pulmonary valve, venous P valve, in 2013. He has more than 360 peer-reviewed published articles, 9 books, over 60 book chapters, and hundreds of abstracts. Professor Hijazi is the founding president of PICA Society and past president of SCAI. Over to you, Professor Hijazi.
Greetings, everyone, from Doha. This is Ziad Hijazi. I am Professor of Pediatrics and Medicine at Weill Cornell Medicine and Chief Medical Officer at Sidra Medicine. Thank you for inviting me to be part of your symposium. Unfortunately, I could not be with you due to prior commitment. Today, we're going to talk about device closure of acquired VSDs. This is my disclosure slide. I am a consultant for Occlutech, a company that manufactures devices. So ventricular septal defects can be divided into 2 major groups: muscular VSDs as well as perimembranous VSDs. Of course, the perimembranous VSDs are the majority of VSDs, about 70%, and 30% the muscular VSDs. Muscular VSDs could be congenital or acquired. Same for perimembranous VSDs. They could be congenital or acquired or iatrogenic. Today, we are going to focus on the post-infarct VSD, and these are almost exclusively muscular ventricular septal defects. So ventricular septal rupture complicates approximately 0.2% of acute myocardial infarction. In the era before the gastro triad, before thrombolysis, it used to be 3%, but with the introduction of thrombolysis or PCI, now the incidence is rare at 0.2%. In the US, we see every year approximately 3,000 cases of ventricular septal rupture. Females are affected more commonly than males. The most frequently, these defects are seen by the end of the first week after the infarct, and these patients have grave prognosis. The 30-day mortality is up to 74%. And I want you to know that there is continued maturation of the infarct size. Of course, this is important because when you close the VSD in the acute phase, you think that you achieved complete or near complete closure, but as time goes by, more and more residual shunt happens because of the maturation of the infarct. The location of the infarct, majority of the time, is the anterior MI, 50 to 70% of the time, but 30 to 50% are inferior defects. Compared to MIs without septal rupture, the infarct artery is more commonly the LAD, and the infarct artery is more totally occluded. Most frequently, patients have 1 to 2 vessel disease. If these patients surgically treated, they have better survival than if they are medically treated, 47% versus 94%. Recurrence of the defect usually is due to patch dehiscence, or the surgeon may have overlooked a second VSD or the development of a new VSD. Poor prognostic factors: if the patient presents with cardiogenic shock, or if the MI is inferior in location. The current guidelines by the American College of Cardiology and the American Heart Association, you have to do immediate intervention. And we will discuss with you at the end a flow chart as to when to intervene. Because of the poor data, in collaboration with our colleagues, the surgeons, the STS Society, they went and they collected all surgical cases from 1999 to 2010, approximately 3,000 cases. The mean age was 68 years. In this case, majority were males at 56.5%, 7.5% had prior CABG, 33% had a prior PCI, and 65% of these patients were on intra-aortic balloon pump. 35% had urgent intervention and 50% emergent intervention. Concomitant CABG was performed in approximately 64% of the cases. The operative mortality by the STS was approximately 54%. However, if the intervention was then done less than 7 days, the mortality was 54%. But if it was done beyond 7 days, the mortality was much less at 18.4%. And again, combined morbidity and mortality was very high at 77% of the patients. Odds for death increased if the patient was on dialysis before surgery, if they were older in age, if they were female, if they presented with shock, if they were on intra-aortic balloon pump, and if they had MRI, and of course, if it was a redo or they had emergent surgery. However, if they presented longer time from the MI, and if they had hypertension or congestive heart failure, the odds of death was less than that. Interventional experience was limited, and as I said, medical treatment mortality is very high, 94%. So it's either you have to do interventional therapy or surgical therapy. And we discussed the surgical therapy by the STS and with approximate mortality of about 54%. So now let's discuss device closure. Initially, it was case series. Landsberg was among the first group in Boston to present data on post-infarct VSD. They had 18 patients, 7 patients with no prior intervention, 4 had deaths, and the 3 survived. The survival were all in the chronic patients, i.e. the VSD diagnosis to intervention was longer than if they were done acutely. 11 patients with post-surgical or residual VSDs, 8 of those survived and the 3 died. The device that is most commonly used is the ambulatory muscular VSD device. And as we know, the muscular VSD device is available in 2 formats, one for congenital VSD and one for post-infarct VSD. The post-infarct VSD device is not yet approved by the FDA, but it is approved by the CE mark, and we have access to it on investigational basis. The difference between the post-infarct VSD or the congenital is simply the length of the waist, congenital 7 millimeter, post-infarct 10 millimeter, and the discs are at large at 4 millimeter. Also, the sizes in the congenital only up to 18 millimeter, the post-infarct all the way up to 24 millimeter in diameter. And this is a waist diameter. So when you do a TEE, you need to look at the location of the VSD as well as the size of the VSD and the number of VSDs. My protocol, the way I prefer it, I'd like these patients to be under general endotracheal anesthesia with continuous TEE monitoring. I prefer to have intra-aortic balloon pump. I assess the hemodynamics. We cross the VSD usually from the left ventricle side, which is the smaller side. Balloon sizing is optional. Some of my colleagues do it. I tend not to do it unless if I'm not sure whether I am crossing the larger defect or a smaller fenestration. We establish arteriovenous loop, and then we deploy the device usually either from the IJ or from the femoral vein, depending on the location of the VSD. Here is an example, 84-year-old lady presented with acute MI 4 days later was found to have horizontal murmur. Of course, it was a VSD. Her QPQS was large, and you can see the images here. This is TEE images showing you large ventricular septal defect. You can see it right there. We cross the VSD, and once you cross the VSD from the left ventricle side to the RV, to the pulmonary artery, you snare the wire, usually from the IJ, if it's apical or posterior inferior. If it's anterior, I prefer to snare from the femoral vein and exteriorize the wire that way. And then you put the delivery sheath either from the IJ or the femoral vein all the way to the mid cavity of the left ventricle. Then you deploy the LV disc, as you can see here, in the LV side. You bring the whole assembly towards the septum, and then you deploy the waist and then the RV side. And then you do angiography or TEE to ensure that the device position looks good, like this in this case. Once it is good, you go ahead and release the device. And then you assess your result. Another example, this is a 62-year-old gentleman, had end-stage colon cancer, but his VSD was much larger than the first lady. You can see this is a large, on the 4-chamber view by TE, you can see the defect is very large, posterior inferior defect. This defect was not amenable for device, was amenable for device closure, but the post-infar VSD was small for this patient, so I had to use a large ASD device to be able to position it there. But even with that, this patient passed away. My personal experience reported in CCI journal, we had 17 patients, and actually the paper, we added one more patient, 6 male, 11 females, median age was 76, history of congestive heart failure, 11, shortness of breath, 8, 5 patients were on intra-aortic balloon pump. Anterior MI in 5, inferior in 7. Time from MI to VSD diagnosis, 50% less than 1 day, so it's acute. And prior attempted surgical VSD closure was in 7. Time from VSD to intervention, 4 patients were done in the acute phase, and the remaining were done anywhere from 13 to 95 days. As I mentioned earlier, the longer the time to intervention, most likely these patients had natural selection. They want to live, and they will survive. Localization of the VSD, as you can see here, 5 apical, 3 mid-muscular, 5 posterior inferior, and 4 were poorly defined. The median size of the VSD was 13, were all done under general anesthesia, but 13 general endotracheal anesthesia. Procedure time 126 minutes, fluoroscopy time 35 minutes, successful delivery in 15 out of 17, device size anywhere from 16 to 24, delivery from the IJ in 13, and 2 were from the femoral vein. Immediate procedural outcome, 2 were closed completely, residual shunt was in 4 patients. At 24 hours, the 2 remained to have continued complete closure, and in the rest, they had residual shunt. Complications in 1 patient had hematoma requiring blood transfusion, and in 1 patient had transient worsening of the LV function. Mortality, we lost 7 patients, and this is a list of all these deaths, and one of them all the way after 57 days due to renal failure. This slide summarizes the series which has been published in the literature. Total number of patients, 273. And as you can see in the line, it's Holzer and colleague, 18 patients. This is my own series. Nonetheless, 46% of these patients, the VSD was closed less than 2 weeks from the diagnosis, so acute. And then the rest were longer than that. And you look at the 30-day in-hospital mortality in 32%, 30-day or in-hospital mortality for those who received the closure was 30%. So basically the mortality with device closure similar to the data that I presented at 30%. 50% of these patients were in cardiogenic shock, and successful device implantation was 90%. So really device deployment, device placement usually is straightforward in the hands of a good interventionist. So you may ask, what should we do? So this is a flow chart. So if you have post-myocardial infarction, ventricular septal defect rupture, then you can say hemodynamically unstable or stable. Let's take the left-hand side of the slide. Unstable. If they are unstable, you have to do either urgent surgery, or you have to put them on ECMO to delay the surgery, or if you have good interventional team, you can take them to the cath lab. And as I mentioned, intervention as soon as possible. And oftentimes we do these cases in the middle of the night, because if you wait until the morning, you may not have a patient to intervene on. On the right-hand side, if the patient is stable, then you can wait if you want. If the VSD is small, you can wait until the patient is stable, and then you can delay either surgery or preferably device closure. If the VSD is large, we recommend to close it after reduction of the amount of shunt. You need to put them on oxygen, but minimize the amount of oxygen, because the oxygen is vasodilator. You put them on afterload reducing agents. You also, it is recommended to place them on intra-aortic balloon pump. So it's really important for you in your center to decide on a strategy, whether interventional strategy or surgical strategy. And again, the two teams have to work together so that we can achieve the best results in these patients. So in conclusion, results of device closure of post-infarct VSDs are still not ideal. Treatment algorithm based on how stable the patient, closure and revascularization of the culprit artery should be attempted if the decision is to go to the cath lab. We are still in search of the ideal device. Thank you for attention, and I hope I see some of you in Chicago for the PICS Symposium. Thank you.
Thank you, Professor Ziad Hijazi. Now the symposium is open for discussion. The audience can ask questions and I invite for discussion into all three topics: PTMC, VSD device closure, and the VSD.
Can I ask for a first question from Dr. Sailendra Singh? Any precautions for doing PTMC in pregnant patients, and the best timing of doing PTMC? I think Dr. Sailendra Singh, are you there? There. Dr. Sailendra Singh, you are there? He's not there. You can. Any questions from others to other two lecturers?
Is Professor Ziad there?
Yes. One question about ischemic VSD. I had a couple of patients I manage medically. Actually, they are doing well. I just want to know when to decide on medical management. It's not there.
I think the experts in the audience can answer the questions.
Of course, pregnancy we try to do after 20 weeks because it affects the fetus, and most likely should be done during the second trimester. Because third trimester, of course, there will be problems. You better do the second trimester. Anyway, after 20 weeks.
Yeah, the PTMC can done in any stage of pregnancy depending on the requirement. But it is the best time, as Vazira said, it's the second trimester. But say if a patient come in third trimester and in severe pulmonary edema, intractable pulmonary edema, which is not manageable with the medicines, then of course you can do it. It is difficult, but you can.
Shall I also ask a question on PTMC from the experts here. Have you, if there's an LA clot, have you tried? He mentioned that you can use a multi-purpose catheter and do the PTMC. Have you anybody tried here that way?
LA appendage closure, of course, not a contraindication.
No, LA.
Yeah, with
LA.
free LA, well, I don't think. Of course, once I had a young boy came with LA appendage, but it is the clot was going into the left atrium, huge bulk glitching. But that, of course, had no choice because he was on ventilator. So we did very careful looking at the TOE, we passed the PTMC and we dilated and got good results. He got discharged. But if the free wall, I don't know.
Yeah, the LA appendage, I think you need not to worry much. But only thing is you should not direct the catheter towards LA appendage. That's the reason he told in the lecture how to avoid that. So that procedure we have not done, but I think that's a good procedure to follow, because then if you follow that, you will not direct your catheter into the LA appendage.
I've also found that puncturing the septum at a slightly higher level will prevent the catheter from entering the appendage freely. If the puncture is lower, there's a higher chance of catheters entering the appendage. So if you have to purposefully avoid catheter entering the appendage, if there's a LA appendage clot, I would suggest to puncture the septum at a slightly higher level. That will prevent.
But the manipulation is going to be difficult.
But entry will be going to be difficult into the valve. About Ajit's question, I think about medical management of the acquired VSD, I suppose once the acute stage is over, it will depend on the shunt, the QP-QS ratio and the amount of shunt, development of pulmonary hypertension and failure, whether you are going to send the patient for surgery for VSD closure, isn't it?
Any signs of decompensation, I think you can't medically manage. So, but some very rarely we come across, I have come across one or two patients with very tiny VSDs and no pulmonary hypertension, no decompensation, and the gradient across the VSD is very good, more than 100 millimeters, and then that's at a sort of a VSD I think you can consider managing medically. We have in the questions, we will conclude these sessions, and although the speakers are not online, I thank Dr. Sailendra Singh, Professor Krishna Kumar and Professor Ziad for their excellent lectures and guidance. Thank you.